All right, and I have 7 o'clock, so we'll just get going. And, okay. I will continue to let people in as people join. All right, well, good evening. My name is Suzanne Giuffre, and I'm an instructor for therapy ed. Tonight I'm doing your GI online office hours. All right, so let's get started. So GI and GU on the exam only makes up about 4.5%. I've said this a lot of times, some students fail by a small amount or pass by a small amount. So we do want you to get through all of the content so that you're as ready as you can be for the exam and can answer all the questions, right? So we're just going to go over GI tonight. Of course, there's GU on the exam as well, because we're doing a lot of pelvic health these days and we need to know something about that. All right, so what we're going to do is we're going to use a lot of polling tonight, but I also do have a couple times we're going to use chat. So I'm going to go ahead and launch the poll because we're just going to start answering questions right off the bat. Okay, so you should be able to see the poll. Here's your, oh, let me let 2 people in. I got 2 people in the waiting room real quick. Okay. All right, let's look at the first question. Here we go. Which of the following is the most likely to disrupt and decrease the normal bacteria in the gut? So we'll start off, I think, fairly easy. All right, and I usually look for, once I get about 75% of people answering, usually I'm moving it on. So right now I have 60% of you. All right, I have 75. I'm going to end the poll. Go ahead and share it with you. Okay, 79% of you said, hey, it's antibiotics. Okay, let's see, is that right? That is right. Very good job. Okay, so yeah, antibiotics are great, right? We need them when we have infections and everything, but we do have normal bacteria on our skin, in our gut, and so antibiotics can actually disrupt that and decrease the normal bacteria that we normally have. I was teaching my students integumentary content, and I was telling them that that people, when they're on antibiotics, are much more likely to get like fungal infections, like athlete's foot and stuff. And that's just because when we're on antibiotics, it decreases the bad bacteria, but it also decreases the good and normal bacteria that helps our body's immune system and such. So, all right, so let me restart the poll. Good job right out the gate. Okay, let's look at number 2. Also, all the way through, if you have a question, just throw something in chat or unmute real quick, okay? And yeah, we'll go through whatever question you've got. All right, a physical therapist arrives in a patient's hospital room and the patient reports that they've just vomited and it looks like coffee grounds. What is the most important action for you to take? Okay, I have about 50% of you. All right, I got 80%. I'm going to go ahead and almost 80%. Go ahead and share. Okay, you guys were between C and D. Yes, it's not A. Nobody picked A. Educate the patient that vomit can sometimes have that appearance. No, it usually, yeah, it sometimes can, of course, because they just did it, right? But it's not the most important action to take. All right, a lot of people didn't say B. Make a note of this, but recognize this is normal in some circumstances. No, it's not normal. And so then we have to decide, do we need to alert the emergency system in the hospital, which has everybody running to us because this is an emergency, or do we alert the nurse and document the information in the chart? So here we're gonna, it's the answer D. So good. Most people said that. We're going to alert the nurse and document the information in the chart. Okay. Or we're going to call the physician, but there's no, that's not an answer. So I might call the physician and just kind of let them know that. If I read it in the chart and I know that that's going on, I may not have to make any action. But if there's nothing in the chart and it seems like I'm the first person to come across this, I need to alert somebody. Because basically what coffee ground emesis is it's when blood mixes with the gastric juices, and when it comes out, it looks like coffee grounds. So the blood is bright red, but it mixes with the vomit. So yeah, we're concerned if they have a GI bleed. All right, so it's not normal. We do want to get it checked out, but it's also not an emergency where we need everybody running to us. Unless they were throwing up huge copious amounts of blood. But they just, no, in this situation, no. Okay, I'm gonna stop sharing. All right, here we go. I think we're on question number 3. A physical therapist is doing a home visit and a client reports that they've had severe diarrhea for the last few days. Which of the following is the most concerning? So all of these are concerning, right? But you need to pick one. So if you could only pick one, what are you most concerned about? Sometimes on the exam, I want you to stop and ask yourself that. When you see a question and you're like, okay, I would do all 4 of these, or I'm concerned with all 4 of these, or something like that. I want you to stop and say, okay, if I had to pick one thing to do, what would it be? Okay, if I had to pick one, and you do, right? The exam is asking you to do that. So don't get stuck on the fact that you would do all 4. Just say, if I was only allowed to do one, which one would it be? What would be the most important? All right, so I'm gonna go ahead and end the poll. All right, you guys are doing awesome. So you guys said B, dehydration. Yes, that's the right answer. So I don't know anything about this patient. I don't know how many trips to the bathroom. Yes, I mean, that is a little bit of a concern. Yes, they could have fatigue, but I don't know anything about this patient. So I don't know that that's my biggest concern at this point. Possibility to dehydration, yes. So diarrhea, it requires, there's a lot of poor absorption of water and it's coming out. So we're just worried about dehydration, right? Most concerned about. The increased likelihood of incontinence. Yeah, we're concerned about that. They're gonna have to change their clothes more often, or they're gonna have to be cleaned up. But I'm more worried about dehydration and then them ending up in the emergency room or having to call a squad because they've got such severe dehydration. The increased likelihood of a urinary tract infection, yes, that could happen too. But again, I'm more concerned about the dehydration. Okay. All right, good. Let me get the next poll. You guys are doing really good so far. Let's see, relaunch the poll. All right, let's look at the next one. An overweight patient reports a current history of a hiatal hernia. Which of the following would be the most appropriate when providing therapy? All right, I have 51% of you. All right. Okay, I got enough. I go to, all right, so I'm going to share it. Waiting for 75. Okay, we were between B and C. All right, let's look at the other ones. Work on abdominal strengthening with sit-ups. If we do that, we're increasing abdominal pressure, and it's going to make the hernia worse. So we don't want to do that. Make sure that PT is scheduled soon after a meal. No, we don't want to do that either. Okay, so good. You guys got it down to the, nobody said that one. Okay, so we're down to educate the patient that weight loss could be helpful, or when doing exercises, supine is preferable. All right, so our answer here is educate them what weight loss might be helpful. So that's true. A lot of people with hernias, sometimes if they lose weight, they can actually reverse that. So when we're doing exercises, you only want to do exercises in supine if you can raise the head of the plinth, or elevate the head. Okay, because again, laying supine, you've got the weight of gravity coming down, and I don't know what exercise you're going to be doing either, but it does again put a little pressure on the abdomen, but also it puts the digestive system kind of like in this horizontal position, and we don't want to do that. So it's just going to cause them more issues with their hernia. All right. Let me stop and do another one. I'm just going to keep moving. All right, let's look at the next one. Oh, wow. This is an educational slide. Okay, so what is a hiatal hernia? It's where the sphincter becomes enlarged and it allows the stomach to pass through the diaphragm into the thoracic cavity. So it can be congenital, it can be due to trauma, anything that weakens the diaphragm, obesity. So obesity is part of that. Or anything that can alter the hiatus. So symptoms are going to have heartburn after a meal, especially if they're laying down. They can have difficult and painful swallowing. My brother had this, and they told him to lose weight, and he did, and it completely reversed. And the doctor was amazed because the doctor said, nobody ever listens to what I say. Nobody ever loses weight when I tell them to, and you completely like fix this problem. It's diagnosed with ultrasound or a barium swallow. So you can see that barium swallow right there. You can see that part of the stomach that's like coming through the diaphragm. They can try and control the symptoms with antacids. Again, you want to have the head of the bed elevated, weight loss, and the prognosis is good. All right. I mean, the prognosis is good overall, but you're going to continue to have reoccurrences unless they manage things with their positioning, the antacids, and again, maybe losing weight. All right, so we're going to use chat. I don't know why I got the poll going, but we're going to use the chat. True or false? When a patient is taking medications for esophageal reflux disease, you do not have to worry about positioning and activities in PT. True or false? All right, awesome. You guys did great. Yes, absolutely. So when you get a question on the exam, they may say the person has GERD, okay, and they're on medications, and then they're going to ask you what you're going to do. It doesn't matter if they're on medications. The medications decrease the acid in the stomach, decrease the heartburn, the symptoms, but it does not fix or close the esophageal sphincter. Okay, so reflux will continue to occur even if they're on medications. And so we still have to think about positioning. Doesn't matter that they're on medication. Okay, I think we have another chat. So here we go. Oh, name one PT consideration when treating a person with GERD. So what's one thing you would think about? Okay, I've got avoid supine. Yes. Timing after the meal. Very good. Elevate head of the bed. Yes. Avoid supine. What is the best position for them to sleep in at night? Do you guys know? What positions do they sleep in at night? Yeah, they should sleep on their left side. So the way I remember it is it's not right to lay on your right. So not right to lay on your right. So they should be laying on their left side. Certain foods, yeah, certain spicy foods and things like that. Okay, let's see what I've got here. Yeah, they want to avoid supine and prone, just laying flat. They want to bend. You don't want them to do a lot of bending. Putting their head down, it increases the abdominal pressure and can cause reflux because they're basically pushing on their stomach, which is going to bring up whatever's in their stomach. Avoid PT after meals, right? A full stomach, there's more that can come up through the esophagus. They should remain upright for at least 3 hours after meals. Pain, I mean, antacids might help. I mean, that can help with the pain. It can help them get through PT. You want to avoid bouncing motions like jogging, running, jumping, because that's just going to take the stuff out of the stomach and it's going to come up through the esophagus. Because that, again, that sphincter is just open. Yeah, somebody said foods, right? Nicotine, caffeine, alcohol, spicy foods, and there's some medications too that if they can avoid them, that would be great. Again, they should sleep on their left side, but they also should be elevated about 6 inches. That way at night when they're sleeping, they don't get that reflux. Drinking between meals, they say, is helpful rather than drinking with meals. So usually tell a patient, you should eat your meal and then maybe an hour or so later drink, and then, then have your meal, and then a couple hours later have a drink. They also say walking after eating is helpful. Just helps everything digest, I think. And they really shouldn't eat or drink something, a lot of something before they go to bed, right? You want to have an empty stomach. All right. Good. Let's see what we have next. Okay, we have another chat. Strenuous exercise can be appropriate with those with GERD. True or false? Should you do strenuous exercise with somebody who has GERD? True or false? Okay. I'm seeing a lot of trues. Oh, I got a false. A couple false. All right. It's a little bit of a vague question. But they do recommend that we don't do strenuous exercise. It inhibits the gastric and small intestine emptying and can contribute to GERD. So again, we can do some light jogging, we can do things like that, but and we have to look at the patient, right? I mean, maybe there's reasons why we need to do something strenuous. We just need to recognize it's probably going to aggravate their GERD. But if we have the choice, we're not going to do something super strenuous. Things that are bouncing, things that squeeze them, we don't want to do that. All right, so I always, when I teach the 2-day therapy ed course, I always bring my water bottle and I say, when you get a question about GERD on the exam, think about my water bottle. The water bottle is my stomach. The water inside the bottle is whatever I ate or drank. I take the cap off the water bottle, and now that signifies GERD because I can't close that esophageal sphincter. So you can see if I lay that water bottle down, the water comes out, bleh, right? So if you lay the person supine, they're gonna be like, right? And it's gonna come up. If I squeeze that bottle, if it's full, bleh, it's going to come out, right? If I shake that bottle, the water is going to come out. So always think about that with GERD when you're thinking about positioning. Well, if it was a water bottle and it had water in it, and I took the cap off of it and I put it in that position, would that be a good thing? So does strenuous not equate with high intensity? Oh, that's a good question. The textbook says strenuous, and they give the examples of like running on a treadmill versus like jogging or walking. That's kind of the what they kind of give us. So intensity, with weightlifting. So you could do weightlifting. I just wouldn't do anything that has them bending, which is going to squeeze the stomach. But, having them lift weights, their arms or their legs, that would be fine. It's more of the like running, jumping, some of that more strenuous exercise than walking or a stationary bike, things like that. Also probably, yeah, I think hopefully that's a good explanation. Okay. Oh, so can you quickly elaborate on why the left side versus the right side? It's because the way that where the stomach is and the way that it curves. So they're saying if you lay on your left side, of course, with your head up, you will be able to keep, they will be able to keep the food or whatever they drank in their stomach. It doesn't, where if they lay on the other side, just because of where the stomach is in the tube, if they have something in their stomach when they go to bed, it's probably going to end up there, it's going to be coming up through that esophageal sphincter. Great. All right, what do we have next? Okay, I think I launched this, so we should be good. Yes, okay. What is the most common cause of severe retching and vomiting as a result of alcohol abuse, eating disorders, or a viral syndrome? All right, I got about 30% of you. I don't know that you would see this on the exam, but oh, relaunch it? I don't think I can relaunch it right now. So probably for the next one. Oh, some of you can't see the poll. Okay. We'll relaunch it for the next one. I don't think I can do that now. A lot of people have already answered to it. So, oh, you need to click on the poll in the bottom. Okay. See if you can figure it out. If not, answer it in your head. Somebody also said left sideline stimulates PNS and relaxes the small intestine as well. Oh, they think that it does. I don't know about that. I'd have to look that up. Yeah, that I don't know about. So anyway, what I was saying is I don't know that you would see this on the exam, but it is in the physical therapy, the pathology for physical therapy book that a lot of programs use. So I was just trying to be complete here, but this is hard if you don't remember this pathology. All right, let's go ahead and take a look at it. I know not everybody probably got to do the poll. Those who did the poll, it looked like we were between C and D. It's actually C. So again, if you don't remember this from your pathology course, I don't think it's as likely to show up on the exam as like GERD and other things. I just want to make sure that you knew about it. So this is lacerations of the lower esophagus that causes bleeding, and it's the most common cause of severe retching and vomiting, and it's due to alcoholism, eating disorders, like bulimia, or a viral syndrome. Okay, that one was a little hard. That one was a little hard. All right, let me relaunch it, and then hopefully we'll have the poll this time. Okay, that should pop up for you guys. All right, let's look at the next one. What gastrointestinal pathology is directly related to cirrhosis of the liver? Again, another hard one. Or maybe it's not hard. You guys are doing good on it. I thought it was hard, but you guys are doing good on it. So maybe I'm wrong. I already got about 60% of you. All right, I'm gonna go ahead and end the poll and share with you guys. All right, so you guys said A. Very good. I thought that was a hard one, but you did good on that. So these are dilated veins in the lower esophagus. It's typically due to portal hypertension, which usually occurs with cirrhosis of the liver. And so approximately 50% of the hemorrhage stops without treatment, but there is a high risk for rebleeding. And although those of you who said Mallory-Weiss syndrome, that can be due to alcohol abuse, which then if they have alcohol abuse and they have cirrhosis of the liver, then they could have this. So they are kind of related. but just because they have Mallory Weiss doesn't mean they'll get esophageal varices. They would have to have enough alcohol abuse to have cirrhosis of the liver. But nice job on that. Okay, I'm gonna relaunch the poll. All right, which of the following is true regarding tracheoesophageal fistulas? I think this one's hard too, but you guys are going to surprise me. All right, I have about 50% of you. All right, I'm gonna go ahead and end the poll. All right, it looks like, oops, I didn't share it. Okay, looks like you guys are saying C. Very good. Wow, you guys are on it tonight. Yes, that is true. Okay, so it's congenital, so it's not something acquired later in life. It's congenital. We really don't know the cause. But it is fairly common, 1 in 4,000. It's more common than I thought it was. And I'm a pediatric therapist. I think this is just dealt with before I see them or something. Maybe they have even told me it's in their history and I've just kind of glossed over it. I don't know. But the esophagus fails to develop properly, and there's a connection between the esophagus and the trachea. So they have a lot of drooling, they can have aspiration. Surgery is required. Otherwise, it's actually fatal because they just start aspirating so much. I mean, these are babies, right? So they don't understand every time they swallow to tuck their chin or whatever. And so they've got to have surgery for sure. Wow, you guys did awesome on that. Okay. I'm gonna relaunch the poll. All right, here we go. Which of the following is related to the use of anti-steroidal, anti-inflammatory, oh, sorry, said that wrong. Non-steroidal anti-inflammatory drugs, NSAIDs. Okay, I have about 50% of you. Why did I not just put NSAIDs? Because that's not an approved abbreviation on the exam. It will be spelled out. If you don't know the approved abbreviations for the exam, because GERD, I don't believe is one either, go to the NPTE candidate handbook. All 50 approved abbreviations are in that handbook. You know them, okay, but I do always suggest students take a look at it before the exam. All right, this one was an easy one, I think. Share results. All right, you guys said A. Yes, that is correct. Okay, so yeah, our NSAIDs causes gastritis and peptic ulcers. So it's the issues at the stomach. They're going to get gastritis first. If they continue to take NSAIDs, then that gastritis starts to eat through the lining of the stomach until they end up with a peptic ulcer. So this is definitely something as PTs we need to know about because we have patients on NSAIDs. All right. Let me relaunch. Okay. All right, here we go. Oh, nope. All right, so what is gastritis? Inflammation of the lining of the stomach, can be acute or chronic. Again, aspirin, NSAIDs, anemia, autoimmune disorders, bacterial infections. Most common is H. pylori, alcohol. Symptoms are going to have epigastric pain, bloated feeling, loss of appetite, nausea. It can be diagnosed through an endoscope, or they might even do a biopsy. And they're basically told to avoid those irritable substances. And if it's because of the bacterial infection, then that bacterial infection needs to be treated. Peptic ulcer then is when it continues and then it breaks through the mucosal lining. And now that it's exposing that underlining of the stomach to the gastric secretions, which is acid. Peptic ulcers can happen in the stomach or the duodenum. And again, it's because of NSAIDs. It can be because of prolonged stress. You hear of people with really stressful jobs, or maybe during PT school, right? You're so stressed. Your just body increases the acid and everything like that. Again, that bacteria puts somebody at higher risk. They're still going to have the epigastric pain, but now the pain's going to be worse. It's going to come in waves and last for minutes. It can actually refer. So they can get midline pain in the thoracic spine from about T6 to T10 with radiation into the right upper quadrant. And again, treatments, avoid all those substances, get antibiotics for the, for the bacterial infection. The prognosis is good unless they just continue with that stressful job or whatever, and then they can have some massive hemorrhaging, and then that could be an issue. All right, I think we're ready for the next. Nope. Okay. I shouldn't have launched the next poll. Ignore that. Okay. This is a stop and think on your own. I want you to look at the organs on the left and look at the referral patterns on the right. And can you match them? I'll give you about 20, 30 seconds to see if in your head you can match them. All right, ready to take a look? Got to know referral patterns. So these are the ones for the GI organs. Let's not make it harder than it is, okay? So here's how it goes. The esophagus, it was the highest thing, right? So that's the one that's going to be between the scapula, okay? Underneath our esophagus is our stomach. So that's going to be under our sternum, or it's going to be in like the mid or lower thoracic. The small intestine is lower, right? So now that's pain that's above the umbilicus. And then the colon underneath there. And so that's going to be below the umbilicus. And then you guys make sure you know McBurney's point, right? We're going to find the umbilicus and the ASIS, and your appendix is on your right side. So you're going to go a third of the way from your ASIS on the right side towards that umbilicus. You're going to push really deep and slow and then let go. A lot of times they have more pain when you let go. They call it a rebound sign because that the infected appendix bounces back when you let go and it causes pain. So we definitely have to know McBurney's point. All right. Here's another matching one. I want you to know about the cancers of the GI system. So read through these and see if you can match them up. All right. This is the way I would look at this. I have one common and two uncommon, and one that's really cancers that come from other organs. So looking at these cancers, which one is the most common? Put in chat, which one's the most common cancer? And actually, it's one of the most common cancers in the US. Yes. Colorectal. Yeah, colon cancer is like number 3 in the US. So that one, I'd say, okay, that's one that's really common. So I match that up with common cancer has long pre-invasive phase and grows slowly, which is a good thing. And now that we have things like Cologuard and things like that, hopefully we can catch those quicker. All right, and then I look at the next one, uncommon, possibly related to GERD. So what happens with GERD, right? The acid in the stomach comes up through the esophageal sphincter to the esophagus. So I'm like, ooh, maybe that's esophagus. Then I don't know about number 3, mostly spread, I do know, but mostly from spread of cancers of adjacent organs. But let's look at the next one, uncommon, possibly related to chronic gastritis. Well, where does that happen? Right? The stomach. Okay. So let's take a look at them. Yep. Esophageal cancer is uncommon, related to GERD. Risk factors include tobacco and alcohol. Again, pain between the scapula, problems with their swallowing. Stomach cancer, uncommon. But when people do get it, it's possibly related to gastritis, those NSAIDs, right? Prevention is fruits and veggies, maintain a healthy weight, limit salt, preserved foods. Yes, colon cancer. That's one of the cancers you want to know for the exam. It's the second leading cause of cancer deaths in the US. It's the third most prominent. Risk starts at age of 40. Okay, so if somebody comes in and they're having changes in their bowel habits or they're noticing blood in their stools and they're having pain below their umbilicus, you might be thinking this. Small intestine, mostly the cancer, if they get it there, it's from other organs that have spread to the small intestine. All right. Okay, I think I have the poll open. Hopefully you can find it now. I do have it open. Which of the following GI pathology has a 50% mortality rate? Ooh, that don't sound good. Now, would you be asked this on the exam? No, but they might want to see, if they give you signs and symptoms and stuff, they might want to see, which one would you act on quicker or trying to think how they would put it in the question on the exam. I don't think they would ask you this exact question. Oh, I know how they'll ask it. Okay, but I'll wait till we finish this one. All right, I have 73% of you, a couple more, and I'll end the poll. All right. Okay, I'm sharing the results. Okay, we're on the right track. The answer here is peritonitis, but why do people get peritonitis? They get peritonitis, one of the ways they get it is when the appendix bursts. So appendicitis doesn't have a 50% mortality rate unless the appendix bursts and causes peritonitis. So it's a little bit of a tricky question, right? Because a lot of us have had appendicitis, and as long as we get to the hospital and they remove the appendix, no problem, right? It's when it bursts that's the problem. They get the peritonitis. The peritoneum is sterile. You can see that kind of picture up there. The peritoneum is sterile. When the appendix bursts and goes into there and they get peritonitis, they get this thick, like pus and stuff that covers that surface. It then can lead to fibrosis, adhesions, obstructions. They're just going to have like general abdominal pain that gets worse and worse and worse till they end up at the emergency room. And then despite antibiotics, surgical drainage, debridement, and everything that they do, unfortunately, mortality is still pretty high, especially for the older adults. So how would they put this question on the exam? I think they would give you that there was a positive McBurney sign, and then ask you what you're going to do. What you're going to do is send that person to the ER. That is an emergency situation, because if it is an appendicitis, they need to go to surgery so that this doesn't happen. So I think that could be the way that it's kind of presented on the exam. All right, what do I have next? Okay, chat. Name one assessment technique that can be used to differentially diagnose appendicitis. Now, I already said McBurney sign. What other one? There are others. How else might you figure it out? Soez test, okay. Obturator test, okay. McBurney sign, percussion of the area, pinch and inch, very good. Percussion there, okay, good. So just in case they throw some of these things on the exam, I don't want you to be like, what is that? Okay, so let's look at them. Well, if they have pain, right, in the right lower quadrant, they have pain with, nausea, vomiting, low-grade fever, elevated white cell counts, all of that. But that's not what you're going to be doing, right? You might see that, well, you might, when you ask them about their pain, you might see that that's where their pain is. And in your subjective history, or if you have, they had labs done or something like that. But more what we're going to do is McBurney's point, also called a rebound sign. We already talked about that. People said obturator test. Yes. So pain with passive right hip internal rotation and flexion. Basically, the thigh, you're putting the thigh squeezing up onto where the appendix is. So as sign, somebody said that. That's pain with passive right hip extension. You can lay them on their left side, do right hip extension. It pulls on the area where the appendix is. Somebody else said pinch an inch. Yeah, you just pinch the skin, lift it up and let it go. And it seems crazy, right? That in itself would cause pain, but it does, or it can, okay? And then pain that increases with any intra-abdominal pressure doesn't mean that it's appendicitis, but that's basically what we're doing with these things. So if they were like, I came in, I'm not feeling good, I've got this pain, and they say something like, well, every time I bend over today, I've got pain. Oh, okay. So they're putting pressure where that appendix is, and that could lead you to, okay, let's do something else. Rosing's test, that one I don't know. So who can tell me what that one is? The Rosing's test? That one I don't know. That one's a new one for me. I'd have to look that one up. But if you can explain it, you can explain it to us. I think I saw a couple of people put that in. Or Rosing's test? Okay. I'm not sure. Yeah. But if anybody knows exactly what that is or how you do it, put it in the chat. Something definitely that I'll look up at the end and see. Okay. Pain elicited in the right lower quadrant with palpation pressure in the left lower quadrant. Oh, okay. Okay. I could see that. Yeah, I could see that. Because if you're pushing on the one side, I could see that it would affect the other side. Okay, perfect. I learned something new tonight. Thank you. Awesome. Okay, I'll have to add that one next to my PowerPoint here. Great job. All right, let me see. I don't know if the polling's up. Nope, let me restart the polling. Relaunch. How long should a physical therapist avoid heavy lifting and straining with a patient after they've had a hiatal hernia repair or hernia repair? Hernia repair. And again, this one came right out of the Pathology for Physical Therapy book. All right, I got about 66% of you. Nobody's saying 1 to 2 weeks. Good. Yeah, it's gotta be more than 1 to 2 weeks. So Good, nobody's saying that. Looks like we've got it down to 2 answers. Okay, looks like we got it down to B and C. Okay, I am sharing it. Okay. And the therapy or the pathology book says 4 to 6 weeks. They say 4 to 6 weeks, heavy lifting, straining should be avoided after surgery. Now, of course, we're always going to go with whatever the surgeon tells us, but your pathology for PT book says 4 to 6 weeks. So something maybe to take note of. All right, let's see if I have another. I think we're getting down to the end, but let's see. Yep, I have another one. Okay. A client diagnosed with a sports hernia or athletic hernia, same thing, is referred to physical therapy. Which muscles would the physical therapist not want to stress, as it will aggravate the condition? Did you learn about this in school? I think we think a lot of these GI things with older people, but not necessarily. This is something you can see in a high schooler. All right. It looks like we are down between hip flexors and hip adductors. Okay, so the answer here is hip adductors. Okay, so good job. So a sports hernia is a weakness in the posterior wall of the inguinal canal, resulting in chronic activity-related groin pain. So it's not always clinically detectable, which means we're really kind of listening to what they have to say. We would actually really have to recreate exactly what they're doing. But the adductor contraction, or we're doing adductor contraction, that can probably tell us. So when they're using these adductors during sports, it creates a shearing force across the pubic symphysis, and it stresses the posterior inguinal wall. So adductor tenoperitonitis, no, that's not what that says. Well, it's like a tendonitis, right, can occur as well. All right, so the adductors. Okay, which of the following is due to weakening and pocketing of the intestinal walls that become infected? And I'll start the relaunch. All right, I got about 50% of you. Looks like we're down to 2 choices here. All right, let's go ahead and end it. So the key word here is that they become infected. So those of you who said diverticulosis, yeah, it's when the intestinal wall becomes pocketed, but then when it becomes infected, it's diverticulitis. So that would be D. Yeah. So diverticulosis, you can see this picture up here, they get these pocketings, it kind of like gets punched out, and they get these, yeah, just like pockets. And then once they end up, things get caught in there and it gets infected, that's when it's diverticulitis. Yep. Why does it happen? Just atrophy, weakness of the bowel muscle, obesity, poor diet, chronic constipation can cause that as well. All right. I'm pretty sure we have another poll, so let me just get it ready. Which of the following is the most common disorder of the GI system and not related to a structural or biochemical abnormality? Abnormality. Can't even say it. Abnormality. All right, I got over 50% of you. All right, got over 75. Share the results. All right, you guys are saying it's A. Yep, that's right. Nice job. Irritable bowel. So it's a group of symptoms. It's the most common disorder of the GI system. About 20% of the population can become a chronic condition. And we don't really know why. It's a functional disorder. Symptoms cannot be attributed to any abnormality of the GI system or any biochemical. They just think maybe it's due to a hypersensitivity that some people have, or maybe altered GI activity, or maybe it's even processing of the nervous system. Like they don't really know. So to make the diagnosis, because there's no really even like test, somebody has to have 3 months of abdominal pain. It's relieved by a bowel movement. And they have to have 3 or more of the following. They have abdominal bloating or distension, passage of mucus or hard or loose watery stools, change in the frequency of stooling, difficulty passing stool, again, like the constipation. The pain can be steady or intermittent. It's usually a dull, deep discomfort with sharp cramps in the morning or after eating. But they don't really know why. Some of the other GIs, like we kind of know why, right? This one, they're like, yeah, it's not really attributed to a structural or biochemical reason. All right. Let's restart the relaunch. Which GI pathology can have joint involvement? All right. This one, we've got like a 3-way tie. All right, we've got like a 3-way tie. This one, the answer is inflammatory bowel disease. So joint involvement ranges from, some pain, only to some acute arthritis, which is common. Arthritis usually comes on abruptly and it will peak within a certain number of hours. They're going to get pain, erythema, some swelling, limited joint range of motion. So arthritis is related to inflammatory bowel. I know we only have about 7 or 8 minutes. I don't remember how much further we have to go. I don't think much, but I'm going to finish. As you know, this is being recorded. We put it on YouTube. It'll be on YouTube tomorrow or the next day. And so if you do have to leave right at 8 o'clock, you can always catch the remaining on YouTube. But I will finish. I always finish, even if it takes me a lot longer. But I think we're getting close to the end. Which of the following are classified as inflammatory bowel diseases? And again, not the type of question you would get on the licensure exam. It's to like spit back the fact, but I'm trying to give you the information and make sure that you have it for when they put it into some kind of scenario or something. All right, let's see. People are saying it's Crohn's disease and ulcerative colitis. Yes, that's correct. Okay, so inflammatory bowel diseases refer to 2 inflammatory conditions, Crohn's and ulcerative colitis. So celiac is a immune-mediated condition. It's genetic. That's obviously when the ingestion of gluten causes inflammation. Short gut syndrome is when somebody's had a resection to part of their gut, or they were born with a shortened gut, and they're going to have problems with with absorption of nutrients, so they have a malabsorption type of a syndrome. All right. Nice, you guys did good on that one. All right. Oh, no, it's a chat one. What pathology is an obstruction located at the distal opening of the stomach into the duodenum? Do we know that one? I'm not seeing anything in chat, so let's just give you the answer. This is that pyloric stenosis. Okay, good. A couple people got it. This is congenital. It's an obstruction right at that sphincter. So you can see the pictures below. So this one's showing a normal opening. This one on the right, they have that real thickening there. And so it's going to restrict the stomach emptying into the duodenum. They think it's increased third trimester maternal gastric secretions associated with stress. It makes that pyloric muscle, kind of get stronger and bulge, hyperplasia of it. And it's going to be an issue. So it's more of a congenital or something they're going to probably diagnose with the baby when they're younger. All right, let's put it all together. I have 4 remaining questions before we wrap it up. Okay, I've already opened up the poll. All right, let's see. Number 1, which of the following accurately describes the difference between gastritis and peptic ulcers? All right, I got 60% of you. Doing good. All right. All right, people said B. Nice job. Yep. All right, so yeah, gastritis again is that inflammation. Peptic ulcers when it breaks through that mucosal lining. They both occur in the stomach. They both can be caused by NSAIDs or that H. pylori bacteria, and neither are typically treated with surgery. So kind of going back here. So they don't occur in different areas of the GI system. They're both in the stomach. They're both caused by NSAIDs and that bacterial infection. They're both are treated with antibiotics, but one is treated with surgery. No, neither are really treated with surgery. Okay. Let me, oh, I should have got the polling ready. Let me stop. Relaunching it. Patient arrives at your clinic with the complaint of back pain. Their pain is noted in the lower thoracic spine area and under the sternum. All your tests and measures for musculoskeletal issues are negative. You think the pain might be referred pain. A pathology of which of the following would be the most likely cause of the pain? So referral pattern. All right, I got 65% of you. All right, good job. All right, most likely going to be the stomach. Esophagus would be my next thing, right? That's a little bit more higher. I try to put lower thoracic here under the sternum to really kind of push you more to the stomach. I might still be thinking, could this be the esophagus, right? Because it's not that much difference. But really when they start to say under the sternum, I'd be thinking a little bit more stomach. Probably the most likely would be stomach. Again, it just goes back to those referral patterns that we talked about tonight. All right, I think we have one more question. Okay, here we go. A 55-year-old patient being treated for a shoulder rotator cuff tear arrives to PT and reports they're having stomach pain for the last week. With questioning, they admit blood when having a bowel movement and more frequent bowel movements than usual. When they point at the location of their pain, you note that it is midway between the umbilicus and the pubic symphysis. Which of the following is the best course of action? Okay, I thought this was a great question, and you guys are rocking it, which means it's still a good question, but you guys have got it. Awesome, 100%, well, almost 100%. Okay, yeah. Yep. Okay, so we don't want to scare the patient and tell them we think they have stomach cancer. Also, stomach cancer, remember, is uncommon, and pain would likely be higher. Remember, it's going to be kind of under that sternum. Educating them on proper hydration and management of constipation, I don't think that's the best course of action here. Teach the patient to avoid heavy lifting or straining, likely an inguinal hernia. With an inguinal hernia, we don't have blood in the stools. And so contacting their physician, telling them what you're seeing, what the patient's been telling you, and you can suggest, do you think this could be colon rectal cancer? Do you want to see them, the age, right? Remember on the exam, the NPTE, they don't give you an age unless it matters. So it's going to be somebody older, the location of pain fits, blood in the stools, it all kind of fits with colon rectal cancer. Oh, okay. I thought we were done. We have one more. Okay, I believe this is the last one. Relaunching. All right, physical therapist is treating a patient for low back pain following a difficult pregnancy and delivery of triplets. The patient tells you they can feel a lump on their stomach. You see their abdomen, see the picture. Which of the following is the most appropriate action to take? All right. Share the results. People are saying B. Yep. Good job. Yeah. It looks like and sounds like a hiatal hernia, and that's not uncommon after pregnancy. So tell the patient this is most likely a hernia, no treatments required. First of all, that's not our scope of practice. So we can't diagnose it. And maybe there can be some treatment, right? Continue PT as usual. As abdominal strengthening will be helpful. Actually, that can make the hernia worse. Refer them to an oncologist because of stomach cancer. No, I don't think it's cancer. It looks like a hiatal hernia. Okay. All right. So one of the questions in chat was, would a dark versus bright red stool be a good question to ask, or any blood in the stool? When we see blood in the stool, especially if it's a good amount, that's a red flag. We always want to refer them to figure out what's going on. A little bit of blood here and there usually is not a big deal unless I've been having it for a long period of time. But you've probably heard of really dark, they call it tarry stools, tarry, like black tar. Usually that means that there's a good amount of blood in their stools, and we would refer them to get that checked out for sure. Not our scope of practice, but if they're telling us that in our history, or we question them because we're thinking something along these lines, we would want them to get that checked out. All right, so everything in bold we covered tonight. We didn't cover botulism. I don't think that would be on there. some of these things I just didn't, cover too much. Oh, peritonitis we did cover. I didn't bold that one, but I don't think you'd see anything on hemorrhoids. Like, I don't think you'd see that. All right, so if you have our books, we do have GI content in the course manual. We also have GI in the other systems chapter in the big review book. If you are taking the exam in April, next week, we are covering ankle ligamentous injury CPGs. And good luck on the April exam. You guys are going to rock it. Those of you who are taking it in July, we always take a break after the exam. We're going to start again May 22nd, and you can see the topics that will be coming from May through June and right up until the July exam. And this isn't on our website yet, but it will be soon. I can always come back to this one, but I did want to make sure that people have my email. It's below. So if you have any questions about what we covered tonight, please don't hesitate to email me. And I learned something tonight. That's awesome. I'm going to add that one test. Yeah, that's great. Hopefully this was helpful. I think you guys did amazing. So you clearly have been studying your GI. You're going to be ready.